Thank you for joining us tonight for our webinar with Dr. Walter Chiles. It's treatment options for BPH, enlarged prostate. Dr. Chiles has been in practice for 15 years. He is a Urolift Center of Excellence, and he specializes in minimally invasive prostate treatments, including treatments for BPH, such as Urolift, Resume, and other minimally invasive options, which he'll be going over tonight. So this is Dr. Chiles, and at the end of our session tonight, we'll be taking your questions. I'm going to hand it over to Dr. Chiles to get started.
I'm Dr. Walter Chiles. I've got some really exciting news to talk to you about some new options that we have for BPH. What is BPH and why is it important? Well, first of all, BPH is really important because it's the top 4 diseases in men over 50. After coronary artery disease, hypertension, and diabetes, BPH is right there. So about 13% of the male population are affected by BPH. Prostate cancer is a little bit farther down the list there at number 10. It's a big deal because it affects a lot of guys. The history of BPH, before we had any medication, first of all we had was surgical options. So that was to remove the prostate. So it can be done in multiple different ways. Enucleation is done with a laser. That can be just a simple deal. Enucleation is the whole leap. And then finally a robotic simple prostatectomy to go in and really remove a large amount of prostate tissue. That's usually done through the bladder, so it's a big operation. Finally, there's other types of resection tissue where you do vaporization, buttons, bipolar. So lots of variations of those treatments. Next, we have ways to injure the tissue essentially by heating or ablating the prostate tissue. Thermal ways, so with microwaves, you may have heard of tuna. There's also chemical treatments. You don't use those very often, but they're almost more theoretical at this point, using ethanol and toxins. And then finally, years ago, we used to use some stents, and we found out that those cause more problems than they help, so we don't even use those anymore. Next, sort of the current state of our BPH patients. First of all, as we said before, that 13% of the male population has it, so that really puts us at 12 million men that are currently being treated for BPH. The way that's divided up is about a fifth of them are just being observed. They're going, I'm doing okay. I don't really need to do anything. 62% are being treated with medical management. So about 7.5 million. Of those guys, about 13 to 15% get tired of being on medication, so they just kind of drop out. Finally, only about 3% of the patients are getting anything done surgically or procedurally. So that's 3% is about 300,000. That's roughly how many are done per year. So a lot of different ways of doing that. So when we took some expert opinions about treatment of prostate cancer, so we just saw that 3% are getting some sort of treatment. We asked the experts, what do you think that, how many people do you think should be getting the advanced BPH therapy? So advanced are the procedures. Think in your head what you think the answer should be. And it's actually 20 to 30% probably should be getting some treatments. That's what about most of the respondents feel. So therefore, lots of people are being undertreated currently for BPH. But do BPH drugs really address the bladder outlet obstruction? First of all, the BPH medications' effect on bladder outlet obstruction is on the minimal side. It can increase the urine flow. It can increase your symptoms, improve your symptom score, but only 15 to 23% increase in your flow rate. So it works. I kind of consider it a base hit. It's not a home run. It's just one thing just to kind of help you out a little bit. The other concern is what happens to the bladder muscle while on medication. So it's prevalent for the bladder muscle to have some changes while you're having some BPH issues. So while watchful waiting or medical therapy is occurring, there can be some changes. I'll show you that here in a little bit. Untreated bladder outlet obstruction, untreated, that's BOO. This is the case for early intervention. So if it's untreated, you can lead to more permanent bladder damage. Surgery provides maximum disobstruction. So the irreversible bladder damage can have already occurred during the medical treatment phase, or if you decided not to have any treatment come in at a later date. 6 months after an open prostatectomy, so those are the people that had to have some of their prostate removed through a big operation. So I mean, they had a really big prostate. Only 61% really had complete resolution of their symptoms. So even if you do something pretty extreme surgically, you may not have cured the patient. So what are the problems with just throwing the medication, the medication first paradigm? Well, first of all, non-compliance. As guys, we just don't like taking medication. We are getting put on so many medications these days that it's really becoming a chore to take them. So the cost can be a factor. Most of them are generic now, so not as big of a factor now. Inconvenient. You forget. You need to take it on a trip. All those sorts of things. And then after time, your prostate continues to grow, so you may lose some efficacy. And of course, side effects. So it's reported that the compliance rate is maybe 29% at 1 year, only 13% at 4 years. So as guys, we're not very good at taking medication, as you know. Too many medications. The Consumer Reports article showed about this. I've jokingly talked to patients and said, you could probably miss a meal as many pills as you're taking because you're taking so many pills. But patients they do want to get off medication. Alpha blockers, these are the standard first line approach for BPH. You may have heard the term Flomax or alphazocin or terazosin or Hitrin. You may be on those. So potential side effects from those is when you first start taking them, you can find that you're lightheaded, you're dizzy, you just may not feel very well, just have some fatigue. Also, when you ejaculate, you may not see much in the way of semen. People also can be very tired, and also nasal congestion can be a real problem. Then some other potential side effects that have been described as a floppy iris syndrome. So the ophthalmologists haven't been real happy with the urologist because it's made their cataract surgery a little bit more difficult. Increased risk of stroke and dementia are out there. Those are still sort of being debated right now if those are big factors or not. And then the other medication that's a standard for prostate enlargement is the 5-ARI, alpha reductase inhibitor. So what those do, those are the ones that actually shrink the prostate. The alpha blockers relax the prostate. This actually shrinks it. Initially, there was some concern about this medication leading to prostate cancer. So that was a concern. And I think the studies have shown that that's probably not as big of a factor at this point. The biggest issue that we're seeing is erectile dysfunction with those patients, and it can be permanent. Decreased libido and some breast enlargement. There's some newly diagnosed things that are taking place too, but those are the ones that mainly I focus on and most concerned about. Why a truly minimally invasive approach is needed? Well, you saw the number of people that are on medications, and they do help, but they don't completely address the bladder outlet obstruction issues. Untreated bladder outlet obstruction can lead to irreversible bladder damage. So my job as a urologist is to reverse that. I'd like to take people back 10, 15, 20 years off of their bladder and prostate health with the disobstruction. As you saw earlier, only 2 to 3% of people are getting anything done. So you can look at the picture below what a healthy bladder looks like, nice, smooth bladder wall. And then as the symptoms worsen, begin having some striations. Those are called trabeculations. And so that one's starting to look kind of bad in the middle portion. And on the right side, where it says permanently damaged, we see these very large trabeculations, large ridges. And that just, problem with that is the bladder will not open up. And the bladder should be a nice, soft tissue that as your bladder fills with urine, it gets bigger and bigger and bigger. When it becomes severely trabeculated, guess what? It doesn't fill up very well. And when it's not filling up well, you've got to run to the bathroom more frequently. You can't hold it very well. Those are some of the really big problems with permanent damage to the bladder. What's a solution? A procedure with a really fast recovery, with few risks and proven outcomes. Okay, that leads us to some answers. So we saw all the negative things, and so we do have something called the Urolift system. So nice thing about Urolift, we've got a lot of extensive clinical data saying that it's effective. So 5-year durability, proven in the real world. So, and I've got a lot of experience with it. Clinical results across studies and in clinical practice. So you can see there's lots of journals that have shown, and this is a little graph about the outcomes and how it persists. And this one just shows 2 years down the road. Nice great improvement, and then it stays flat. Another thing about Urolift is it's now backed by the American Urologic Association, which is our governing body of urologists. And so now it is part of the standard of care for treatment, which has just been great for urologists and patients. So urologists should consider the Urolift. We should also be aware that it does not cause ejaculatory dysfunction or worsen ED, such as the other surgeries, the TURPs and things that we talked about before. So, and men that are really concerned about this new onset of ED or ejaculatory dysfunction, great place for Urolift. Also, on the AUA guidelines, they recognize the need for intervention. We showed the pictures earlier from the healthy bladder to the worsening damage, to the damaged bladder. But since so many men discontinue medications and we have a minimally invasive treatment, this is an awesome way to get treated. What is minimally invasive? Well, men, first of all, would say, boy, I sure don't want a catheter if I get a procedure done. Next is I want rapid relief. I want relief of my symptoms. I don't want to miss a lot of golf or work. I want to not have any much problem or pain with the associated procedure. And I want my sexual function to not be altered. And then less important with whether it's an office procedure or under local. Urolift has all those advantages. Most of my guys don't go home with a catheter. There is rapid symptom relief. Our sexual function is preserved with this. And I usually do this in either the office or the surgery center, whatever seems to be the best location. And I usually do anesthesia, so don't worry. So how does Urolift system work? This is a little graph that that is helpful. I've also got a little video I'm going to show you here in just a second. But on the far left, this is the enlarged prostate. And this just shows the urethra in the middle there. You can't even see it because it's being blocked by the prostate tissue. Next, that little silver thing, that's my scope, the Urolift device. And so it's in the middle of the prostate. Up at the top is the bladder. And then on step 2, just on the third picture, that shows the small Urolift implant going in, and it's permanently opening that area up. And then finally, step 3 shows 4 implants that have deployed. So if you compare step 3 with the enlarged prostate, how that channel is now farther open.
The Urolift system is a proven minimally invasive technology designed to relieve urinary symptoms and improve quality of life with minimal side effects for men with an enlarged prostate caused by benign prostatic hyperplasia, or BPH. The Urolift system procedure begins by inserting an implant delivery device into the urethra. An attached endoscope provides visibility to the obstructed prostate. On reaching the area blocked by the enlarged prostate, the obstructive prostate tissue is designed. Following a trigger press, the device inserts a fine 19-gauge hollow needle across the prostate and deploys the implant through the needle. The implant is a nylon suture fixed in place with a thin metal tab at each end. Depending on the prostate size and blockage severity, the doctor inserts several more implants the same way. Typically, 4 to 6 implants are placed into the prostate. The outer capsule of the prostate is firm and provides a solid anchor, which allows the implants to lift and hold the enlarged prostate tissue out of the way so it no longer blocks the urethra. As the sutures are shorter than the prostate depth, the prostate laterally compresses. This reduces pressure on the urethra and provides immediate visible results so urine can flow freely. It's a mechanical solution to a mechanical problem. The minimally invasive procedure requires no cutting, heating, or tissue removal. This procedure avoids erectile and ejaculatory dysfunction. It typically also means minimal downtime, mild to moderate side effects, and a quick return to normal activity. The Urolift system provides a clinically proven treatment for those who suffer from an enlarged prostate that can get men off BPH medications and avoid major surgery.
This is a before and after picture. That graphic demonstration is really helpful in showing what exactly we do. Before, this is what I'm looking in with the cystoscope. You can see the 2 lobes of the prostate touching one another. I call them kissing lobes of the prostate, and then after the open channel. And so when we see that, we know the guy's going to have a great response and will be off medication with that result. After treatment, people can expect to start having some symptomatic improvement in about 2 weeks, and then people continue to improve for the next 3 months. Most common side effects are usually mild to moderate, and it's pain with urination, blood in the urine, maybe some pelvic pain, frequent urination. Rarely do people have to come back and get a catheter put in or do anything else. Most symptoms resolve in about 2 to 4 weeks. And once we said before, the durability right now is out at least 5 years. I think the studies are coming to closer to 7 now. In summary, the Urolift system is good for all men with BPH symptoms, and they have to be older than 45, looking to treat people who want symptom relief, who would like to stop medication, who prefer a less invasive treatment, who want to preserve their sexual function, and really are concerned about going through surgery. And then for people who want TURP or laser, but are concerned about their sexual function, this is a great alternative to those people, and also want a rapid recovery and rapid return to their way of life.
Great. Thank you, Dr. Chiles. We do have a few questions. Someone wants to hear a little bit more about the success rate for Urolift, and how do you define that success?
Well, the best way that we define success is really in the eye of the beholder. What I'd like to do before all patients come through is have all my patients fill out what's called an IPSS form. That stands for International Prostate Symptom Score. It's a 5-question survey that is very helpful in finding out where people are before, and then we see where people are after. So that number goes up to 35, and we like to see people less than 10 or in single digits on those scores. And then also we do some test evaluations beforehand called a Eurocuff. So that's a way that we measure the stream rate, and we do that before, and if there's any questions afterwards. And so that'll give us the stream rate and then how much obstruction is there. So those are kind of the two scientific ways of doing it, but ultimately it really depends on the patient. And I would say the success rate, 70 to 80% of people are thrilled they had this done. 10% of people say, yeah, I'm better, that's okay. And maybe a few percentage of people say, I don't really think this was right for me. And that's probably about how the national averages are too.
Can you talk a little bit about, one gentleman wants to know about the steam treatment, which I'm assuming is Resume. Can you talk a little bit about that, please?
The steam therapy, Resume, is one that I do also. And the benefit of that procedure is that it's also a very quick procedure, minimally invasive. And so instead of doing the clips like you saw with the Urolift, we inject steam. And depending on how big the prostate is how often you stick the steam. And so that's just done with some measurements during the procedure. So it's a quick procedure. The downside is the recovery is not as fast, because since there's not a mechanical opening of the prostate, it's done with steam, that it takes 2 to 3 months for you to get full effect. So 100% of those patients do go home with a catheter. So once you put those two things up there, most people end up choosing the Urolift. But I still do some Resume for various reasons, and some people do like that. I get good results with it.
Can you talk a little bit about the expectations for relief after you have the Urolift treatment? Is it going to be 100% effective? Are people still going to have problems at night? What can patients expect?
Every patient's a little bit different, and we do run the gamut of how people respond to it. But a vast majority of patients will be better. You're never going to be how you were when you were 20 years old. And that's what I kind of talked about, people like try and reverse 10, 15, 20 years off your prostate life. So if you're in your 70s, hopefully get you back to where you were sort of in your 50s. So you may get up one time at night, you may be perfect. So that's kind of the way I see it. Ideally, I'd like for you to be doing better than you are when you're taking medication, and be off medication. That's one of my big goals with this procedure, and that's what I think. I just want to put the expectations that 100% better. That's the first rule of medicine. Don't tell anybody 100%, but we do like to see people way better.
Is it possible for the prostate to be too enlarged for the Urolift treatment?
Yeah, and so every one of my patients will have their prostate measured. I do take a feel of the prostate, but a little bit more scientific and precise way is to measure it with an ultrasound. Currently, the FDA and Medicare require the prostate to be under 100 grams, and so that is measured with the ultrasound. So, yes, as you saw, you have to stick the needle through the prostate. So, if it's too large and you can't compress that enough, that's the problem. And so, we would have to move on to one of the other treatment options.
We have a couple of questions asking if the Urocuff is required as a test before the Urolift procedure.
No, it's not required, but it is a helpful test. It's really helpful too for some people who are kind of determining whether they really should even do the procedure, because sometimes people go, I'm feeling okay. I think I'm urinating okay. And we do the test and it shows that you are obstructed and you are starting to do damage to the bladder. And so it really makes it easier to make that decision to move on to a third line option.
We have another question concerning complications with the Urolift, both short term and long term. What can people expect as far as complications, if any?
So the biggest complications or problems that I've had are people who are not able to urinate. They go home without a catheter, and then they get home and they have problems, and so we have to put a catheter back in. I had some people that had some bleeding issues. Never had to transfuse anyone. But as you can imagine, the prostate is a very vascular organ, and so bleeding can be a factor. So short term, a couple of urinary tract infections here and there. But the biggest problem is just burning with urination, frequent urination, not having a whole lot of warning time when you need to go. So those are the first couple of days. I usually tell people the first couple of days, you may not like me so much. After a week, I think you're going to really like me. Long term are just whether the treatment holds up. I haven't had anybody who's had a problem with a long-term issue, and usually it's just because the prostate's continuing to grow.
We have several questions about coverage. Is the Urolift covered by insurance and Medicare?
It is. Medicare covers it very well. Private insurance didn't cover it as well. Now, I think all the carriers are on board with this. So with the private insurances, there are some hoops that I have to jump through, and we have to click off all the boxes. We got to make sure your PSA is okay. We need to look in your bladder, have your prostate measured. So there are a few hoops that we have to jump through, but it's very well covered, I think, by about everybody now. Previously, that wasn't the case. So that's a testament to how well it's working.
This is a question just about BPH in general, but we have somebody who's wondering, does the prostate continue to grow if a person has BPH?
It does. It is just like everything else in your body. It just continues to grow. And so that's why we do tell people that there's probably about a 2 to 3% retreatment rate per year. So over time, as your prostate continues to grow, that 10 years, there may be 20% of people that need to have something else done.
Can you explain the cystoscopy procedure?
The one that we do as a screening is a little flexible scope with a light on the end, and it is put in through the penis, and we look up the urethra. It takes just a couple of minutes. I mean, I think all guys have some sort of horror story about this, but with the local anesthesia that we do, the viscous lidocaine that we put into the urethra, I tell most people it's probably a 2 out of 10 pain and discomfort. With the Urolift procedure, we do sedate you for that because it's much more involved and invasive than the simple cystoscopy. But the simple cystoscopy is very helpful in looking at the anatomy of the prostate. There are certain anatomical features of the prostate which may make you more amenable to one type of treatment of your prostate than another. And so that's why I kind of tailor-made all these prostate procedures based on you, the patient.
Can you talk about who would be a candidate for Urolift? Is there, a certain age, or who would be a good candidate?
I think anyone over 45 is what the Urolift is geared for. Ideally, got some urinary issues, BPH issues. I really like patients that have a response to medicines such as Flomax, because that tells me those patients would do really well with the procedure. And then once again, anyone who wants to get off medication, they have side effects for the medication, they have the dizziness or nasal stuffiness, and it's just one more medication that they don't want to be on. And then we have people on the extreme where people are in urinary retention. They can't urinate at all, or they're just barely trickling out their urine. They may be a very good candidate for Urolift. So anyone with prostate issues. And so, well, one way I get a good estimate of that is with my questionnaire that I do on your visit to my office.
We have a question about taking ED pills. Can you continue to take the ED pills after you have a Urolift procedure?
Yeah, by all means. Previously, were some of the BPH medications and the ED medications, there were some contraindications about taking those together, worrying about dizziness and low blood pressure. It's actually probably even more advantageous to get off the BPH medications after the Urolift and then only have to take the ED medications.
Somebody's wondering if they could drive themselves home after the procedure.
Only if we do the procedure under local. And initially, that's how I did the procedures, under local. And that actually worked very well. Didn't have too many complaints about that. So yes, if we do it under local, that can be done. But most people opt for the sedation method. I'll talk to you a little bit more about the sedation. It's the same sedation that you would get when you get a colonoscopy. It's with the Diprovan medication. And so it's a quick onset and quick recovery from that. No tubes down your throat or anything like that.
Is the Urolift procedure permanent, or would somebody have to get it again later on? How long does it last?
Yeah, great question. The Urolift procedure, we do consider it a permanent procedure, but there are times where the prostate continues to grow and the patient may be a good candidate to add more clips. If you don't have the outcome that you want, or you did great for 5, 6, 7 years, but your prostate continued to grow, yeah, you are a candidate to do a Urolift again. And when you're looking at the other options of a more invasive with more complications, yeah, I think I'd pick going with the Urolift again.
Can you just reiterate, is the procedure done in the office or in a hospital setting?
The majority of the time now, I do it in my surgery center. Initially, before I had a surgery center, I would do that in the office. So I would even bring sedation into the office. It's much more professional to do it in the surgery center, and it's just been fantastic.
Is there a maximum age for the Urolift procedure?
No maximum age. Done Urolift in the people in their late 80s. I don't think I've done any 90-year-olds, but yeah, so it's a great procedure for people who need some help.
Talk a little bit about, we have a question about the clips themselves. Is there potential for them to migrate or move or fall out?
The clips can, they can migrate. I don't think they really migrate throughout the body. I don't have any studies about that. The clip, when you're putting those in, sometimes if you don't get it all the way where you want it, that it won't seed properly. It won't clip and open. And so those we have to remove. I have not had to go in and remove any clips. I haven't really heard of any of them, the clips breaking down the road, but I think it's more just sometimes the prostate can kind of come around if it's a very large prostate, that clip just can't hold it back in. And that's why you need more clips.
And is there ever an incidence where the insert will grow into the prostate?
Sometimes when we put the clips in, as soon as you fire it, you don't even see it because it goes so far back into the prostate. In other ones like the video, you could see it clearly. When they do kind of go in, we don't get worried about how it looks. We just want it to be effective.
Can you get the Urolift procedure with other urologists at Tennessee Urology? Do other doctors do it?
About half the urologists here at Tennessee Urology do the Urolift procedure. So all of them are very well versed in doing it and have a lot of experience with doing the procedure. So if your urologist does it, by all means, I'd feel comfortable with them doing it. If your urologist doesn't offer it, then I'd be happy to see you.
We have a question about patients who are using Eliquis. Does this result in excess bleeding?
First of all, patients on Eliquis do have to be off this medication prior to doing Urolift. It is a minimally invasive procedure, but you can still have bleeding even off Eliquis. So that would be a dangerous combination. So it's really important to talk with your cardiologist, whoever has you on the Eliquis, prior to see if you'd be safe to stop it for about 3 days before and probably 2 or 3 days afterwards. And a lot of patients with heart stents in, that's just not an option right now. So it's just a conversation to have with your cardiologist.
And are there any other contraindications for Urolift?
There's lots of different things that could potentially be an issue. So it's just really important to talk to your urologist about pros and cons of doing it. But there may be some things I'd miss.
Anyone who is interested in making an appointment, you can call Tennessee Urology at 865-351-6644. You can also go online and schedule a telehealth appointment. We are taking in-office and telehealth appointments currently. Visit our website, tnurology.com, to get some more information about Dr. Chiles and the Urolift procedure. And I'm sorry, we have one more question that just came in. What happens if Urolift doesn't work?
Options you have are a repeat Urolift or go into a laser procedure or a TURP procedure. That's where you go and resect tissue out. So there's a lot of options. You're not limited after that's done. So you still have all your options. So if you do the Urolift, the nice thing is that you haven't burned any bridges.
So I think that does it for our questions. Thank you so much for participating with us tonight. Dr. Chiles, thank you so much for all the information you presented tonight. And that will conclude our presentation. Thank you so much for attending.